Hi everyone, welcome to our talk today. Dr. Erica Ortiz, and today we're going to be falls. A little background, I primarily cover inpatient geriatrics, so I often see patients who have had falls or having gait disturbances that lead to falls or other, chronic conditions. And Dr. Ortiz actually helps run our falls clinic at Mount Sinai. All right, so without further ado, we're going to go ahead and get started. We have no financial disclosures. So the talk is broken up into several parts. So we'll begin by reviewing the geriatric 5 M's. We'll define fall. We'll talk a little bit about the prevalence of fall, the consequences of fall, and then Dr. Ortiz will talk a little bit about how we assess for falls, what the managements are, and then we'll wrap it up with based interventions. So before we dive in, we really wanted to highlight the 5 M's of geriatrics, primarily mind, multi-complexity, what matters, and to really highlight it, mobility and medications. These are the two that we really try to hone in when we encounter our patients with falls. Is defined the definition of a fall, right? So a fall is defined as an event which causes a person to unintentionally rest on the ground or a lower level, and it's a result of a major intrinsic event, such as a stroke or a seizure or overwhelming hazard. Now, this is something in geriatrics we really um, focus a lot on because amongst our community dwelling adults, more than 1 in 4 adult encounters a fall event each year. So when you really look at it from a big picture perspective, it really adds up on the total population. Now, there's some things that, the reasons we really, address so strongly is because when you look at the data, 50% of nursing home residents have a fall annually. In the acute care settings, such as hospitals, 15% of our admitted patients encounter falls, despite having nurses, CNAs, doctors, and other healthcare providers working so closely with them. And to really highlight this, patients, especially older patients who have been recently hospitalized, 40% of shortly after their hospital discharge. So fall on an overall, geriatric falls so much because it's associated with many factors, right? So fall and indirectly do ADLs or IADLs on a daily basis. So really, it forces us to go to nursing homes or SNFs, so we could often it's to over 1 million hospital stays annually. It's a huge reason for emergency department visits, approximately 3 million visits annually. And it costs our overall medical system in the US over $50 billion in studies that we really want to highlight for you. So, like these things over the age and the relative risk for 1.1 in a year, the non-injurious fall in an older adult over 71 is 5.5, and the relative risk for at least one fall causing serious injury is 10.2, and admissions to nursing home. To clarify my point a little bit, folks who have had falls, um, what are the risks of these folks actually having to not only just to really highlight the point, we really want to avoid falls because it is a strong predictor of placement to a skilled nursing facility for long-term care. Now, one thing, as we go through this talk, I want you guys to sort of develop like many reasons a person can fall, but it's a negative feedback loop. So, for example, let's say a person falls. Now, once a person falls, it creates a fear of a person's quality of life because they're less likely to go outside, go out for walks, enjoy the things that they usually do, and it leads to, more a less independence, right? That subsequently adds into the fear of falling, and it's like a negative, just a cycle that keeps feeding itself. So it's up to us as providers, as geriatricians, to really identify patients at risk of falls, whether it's through medications, whether it's through, other comorbidities that they have, and really help mitigate that through physical therapy and a few other interventions that we'll be talking about later on. So, what are the physiological changes in older adults that really? So, one thing that we really want to highlight for you guys is the concept of homeostasis. So, homeostasis is the natural decline of our own physiological reserve that we encounter with aging. What that means is, as a person ages, they're less able to maintain the equilibrium during times of stress. And we often see this with our older adults in terms of infections, in terms of hospitalizations. They're more prone to delirium and other complications. So the overall concept to keep in the back of your mind is homeostasis. Homeostasis. It's the decline in the physical reserve with aging and the ability to sort of maintain that equilibrium long term. Now, there are a few things that we really want to highlight for you, systemic basis. So when you break it down and you look at, for example, the cardiac system, the cardiovascular system, we often, our cardiac compliance often decreases. We often encounter patients with impaired ventricular diastolic filling age. So this oftentimes predisposes an older adult. When you look at it from a pulmonary perspective, our respiratory muscles weaken as we age, not only just to wear and tear, but also due to other comorbidities such as obstructive or other restrictive, respiratory diseases. Um, to really, drive it down in terms of nitty-gritty, our FVC and our FEV1s are reduced, which can also put a person at risk of falls. Neurologically speaking, our cortical volume decreases, and then there's also often the decrease in memory and attention span in our older patients. From a renal perspective, we often encounter patients with chronic kidney disease or just overall and lower GFR as we age. From an MS musculoskeletal perspective, our older patients often are less active, they encounter a decrease in skeletal muscle mass, subsequently strength, and a lot of our patients, especially our female older patients, have loss of bone mineral density. So when you look at these systems individually, they may not individually be the primary reason for fall, but when you look at them globally and each one, adding on a little bit, it on a big picture, each system contributes to the overall risk of a person falling from a physiological perspective. Now, the other thing that we really wanted to highlight for you are the age-related gait changes which also predisposes a person to higher risk of fall. Some of the ones we really want you to be familiar with, include slower walking speed, diminished arm swing, diminished hip and knee flexions, and our gait themselves have a more broad-based and reduced step length. And the variability um, of the timing is actually different. It's a much increased. So those are some of the things that I want you to keep in mind. Now, other fall risk factors. So we talked about the intrinsic factors, which is, the cardiovascular thing, the reasons, sometimes visual changes that people experience, the gait issues that we highlighted, cognitive impairment, chronic, the intrinsic factors. These are things that we could change, right, and mitigate. So these include footwear. So if you're wearing shoes that are large, bulky, they could often lead to you falling. Um, a lot of our older patients, sometimes partake in recreational substance use. That could be such as alcohol or even marijuana. So those could really add to that. Home hazards, right? Having furniture, loose carpeting, loose flooring, things like that could really increase the risk of falls. Medications is a big one. Obviously, some visual issues are intrinsic, but a lot of our visual issues can also be corrected through eyeglasses. So having the proper see things and objects around you and obstacles really helps mitigate risk of fall. And finally, improper use of assistive devices, such as, canes or not knowing how to use your walkers, could really add to that risk factor. Now, one of the things we really want to highlight for you are the medications, or we call them FRIDs, medications that essentially are associated with high risk of falls, are very common to you, such as benzodiazepines, your Xanax, your and other benzodiazepines, and also antipsychotics, right, such as quetiapine, olanzapine, also anticonvulsants, TCAs, SSRIs, any sort of medication that can cause hypoglycemia, especially patients who are on insulin, antihypertensives, opioids for pain control, alcohol, and oftentimes in a polypharmacy, right? So it's obviously these medications by themselves alone can cause a high risk of fall, but oftentimes it's the combination of these that really elevates that risk. So it's really up to us to identify these high risk medications and sort of tweak them as needed. So for this next part, I'm going to transition over to Dr. Ortiz, and she'll talk to us about the how we evaluate patients that we encounter in the clinic or in the hospital that have had a fall event.
Okay, so we're going to talk about the false evaluation, like Dr. Kamal said. So basically, we have to know that the CDC has created an initiative that is called STEADY. This is the acronyms for Stopping Elderly Accidents, Deaths, and Injuries. So basically, it has the screen, the assess, the intervene. It means that we're going to identify the patient at risk for a fall. We're going to identify modifiable risk factors, and we have to use effective clinical and community strategies. So they have created questionnaires that we can use in our patients. We have a questionnaire for inpatient and another for outpatient. So for the questionnaire for the outpatient, we have this questionnaire that was created by the VA Geriatric Research Education Clinical Center. So it has 12 questions that they are going to answer like yes or no. Basically, they ask the question if they have fallen in the past year, because if they have a history of fall, they are more prone to fall. Also, they ask if they have been recommended to use a cane or a walker, or if they feel unsteady, or they have to use they have to hold onto a furniture when they are walking at home because it means that the balance is they have a poor balance, and also if they are worried about falling, or even they need or if they need to push with the hands to stand from a chair, or they have problems stepping on up onto a curb, it means that they have a muscle weakness. Also, they ask about if they have the rush to go to the restroom. So if they have the rush to go to the restroom, it usually is frequent in patients that have urinary incontinence, and it can increase the risk of falls, especially if it happens during night. And neuropathy can cause also the risk of fall because they can stumble and it can lead to a fall. There are medications also that is related to this issue. So basically, we have to inquire about medications if they use any medication for insomnia, for depression, anxiety, or also if they are using antihypertensive medication, because it can cause also risk of falls because it can cause orthostatic hypotension. And so it's the questions that we're going to ask. And the last one is how is the mood, if they feel sad or depressed, because it also is a risk for falling. So now we're going to talk about the inpatient questionnaire. In the inpatient questionnaire, we have the Morse fall score. So it has six basically items that we are going to evaluate. One is history of fall. The other is the secondary diagnosis. If they need any ambulatory aid, it can rate it like if they don't need it, or also if they don't need to use it because they are bed rest. Also, if they're using crutches, cane, walker, or if they need a furniture to mobilize, like if they need to use the walls, or they need to use the chairs to hold on to the chairs to mobilize um, around home. So also if they have any IV access, the gait, and the mental status. And it has we score them like low risk, moderate risk, and high risk depending on how many points they get in the questionnaire that we asked them. So now we're going to talk about the laboratories that we can use. So it's important to evaluate other causes that can be causing the patient to fall. So it has to be to evaluate if they have any anemia. So for that, we are going to use the hemoglobin. If they are on risk for dehydration, so we are going to check the VUN, the creatinine, and also electrolytes is important because hyponatremia can increase the risk of falls. We are going to evaluate the glucose and A1C because if they have episodes of hypoglycemia, it also can increase the risk of falls. If you during the physical evaluation you think that it's important to look for cardiac conditions, we will need to do an echocardiogram, or if they need to have if we are concerning for any problems in the spine or any problems in the especially in the lumbar spine that can cause abnormalities in the gait, or like spasticity or hyperreflexia, we can have a spine MRI. So now, just remembering what Dr. Kamal spoke about the 5Ms during the falls evaluation, is important to focus in these 3Ms from the 5Ms. One is the mobility. So the mobility, we have to check, like we talked before, the history of falls, the gait, the balance, the footwear that they use. In the medication, we have to evaluate for medication that increase the risk of falls, the doses of the medication, the polypharmacy in the medical conditions. We have to evaluate if they have any visual problem, any cognitive impairment problems in the cardiopulmonary system, or kidney problems, like Dr. Kamal mentioned it before. So now for the like Dr. Kamal mentioned before, we have the extrinsic factors and we have the intrinsic factors. In the extrinsic factors, we have the medication, the alcohol use, the lack of adequate hydration, if they need any assistant device to walk, what footwear they use. We have to avoid, of course, the high heels. They have to be the footwear has to be comfortable. We are going to evaluate for intrinsic factors to check if there is any cognitive changes, if there is any loss of consciousness or history of loss of consciousness. We have to evaluate for them dizziness, lightheadedness, orthostasis, any problems in the vision, in the hearing, if they have any heart problems like palpitations, if they have urinary incontinence, problems in the muscle skeletal system, or if they have balance problems, or if they have any neuropathy that can cause paresthesia in the feet. So now in the bedside physical exam, so these are things that we have to evaluate after we have the history. When we do the physical exam, it's important to check the virals, but besides that, the orthostatic virals is very important to check for any visual changes, for evaluate for the muscle skeletal system to see any weakness, to evaluate how the patient walk. We need to do a cardiac exam, a neurological exam, and of course to evaluate the balance. For the gait and balance assessment, we have different tests that we do. So one of them that we're going to see in the next slide is the is the talk test, and we also are going to see the other test that is the 4-foot balance. So basically we're going to evaluate on then the functional motor strength, the functional balance, and functional gait and coordination. So how to evaluate for the 30-second chair stance. So basically for the 30-second chair stand, we ask the patient to sit in the middle of the chair. Then they have to place their hands in the opposite shoulder, cross and at the wrist. They have to keep the feet flat on the floor. They have to keep the back straight. They keep the arms against the chest, and then we're going to give the command to go, and we are going to ask the patient to do as many repetitions as they can, and we are going to evaluate this for 30 seconds. And this test is going to evaluate for the leg strength and the endurance. We have to use a chair with a straight back, and without it doesn't have to have the armrest, and the seat has to be with a 16 inches high. And basically we're going to see in the next slide that there is like we have we after we have this test, we have to evaluate how many stands are expected, depending on the age and depending on the sex. So, for example, a young patient from 60 to 64, we expect to have to do it at less 40 to 12, and to if they do less than 14 to 12, depending if it's male or woman, there are more increase of risk of fall, or if they are and it depends on the age. If they are like 90 or 94, it's less stands or less repetitions that we are expected depending on the age. So now also we have the next test that also we evaluate is a 4-stage balance test. So we ask, it has four tests that we are going to do here. One is the patient is going to stand with the feet side by side. The second one, they're going to place the instep of one foot, and it is touching the one foot is touching the big toe of the other foot. The other is the tandem stand. They have to place one foot in the front of the other heel, touching the toe, and the other is the stand on one foot. We evaluate how many seconds the patient is able to keep these positions, and normal is if they are able to maintain more than 10 seconds, but if they do less than 10 seconds, there are increased risk of falls. And basically this test is used for assess the static balance. So now we have the time up and go test. So this is also called talk test. So how we perform this test is we ask the patient to stand up from the chair. They have to walk in a line that we can show the patient, and it has to measure 3 meters is the distance how much they have to walk, and then they have to walk at a normal pace. Then they turn, they have to come back and at a normal pace, and they have to sit down. And like we say, we are going to measure how many seconds they use to do this task. And if they use more than 10 seconds, we can predict that there is going to be an impairment in the ADLs. But if they do more than 10 seconds, there are an increase of risk fall. And if they do more than 30 seconds, we can assume that they are not safe going outside by themselves. So in the next slide, we are going to see other other interpretations that we are going to have as per the test. Yeah, basically it's like if they are less than 10 seconds, so it's going to be like the patient is completely independent. But if it's less than 10 seconds, like we spoke before, the patient is on risk for falls, but still they can be independent, going like taking a shower or transferring from the bed to the chair, or climbing a stairs, or going outside alone. But if it's more than 30 seconds, they will require assistance, and they are dependent in most of the activities. So now Dr. Kamal is going to talk about the falls prevention intervention.
Thank you, Dr. Ortiz. So we'll review what are some strategies that we could use to prevent falls and some intervention that we could implement in our patient setting. So the things that we want to highlight for you include strength, balance, and gait training, chronic pain management, medication review, home safety, and other comorbidity managements. So physical activity, strengthening physical activity is strongly tied with fall prevention. And there's a few papers that we want to highlight for you. This particular study actually looked at physical activity and falls prevention in patients specifically over the age of 65. It was a systematic review, and the WHO actually used to create their own guidelines. Study was, the CT evaluating physical activity of people who live in the community. It involved over 25,000 participants, and it included 16 studies, and essentially showed is that exercise reduced the rate of falls by approximately 25% in older adults, community dwelling. So this really highlights for us that a simple exercise program, how impactful it truly can be. Now, there are additional studies that have been done, right? Including some of these studies that they looked at here that sort of helped hone in on what kind of exercises really are beneficial. So the three that we want to highlight for you are these. So any exercise regimen that focuses on balance, weightlifting or anything like that, those we realized have a risk reduction of up to 25%. It's almost 24%, almost 25%. And this particular study actually looked at 39 individual studies. So it's a very large overall paper that they reviewed. Next, they wanted to highlight sets of exercises that sort of focus on balance, and we do notice that when you add the resistance component to balance and functional exercises, there is a slight improvement of risk reduction, so 28%. But just one of the things we wanted to highlight is that just because you have a patient that you're caring for that isn't able to participate in resistance exercise, it doesn't mean that you completely are not physically active. So these two studies really go to show that just balance and functional exercise alone can give you a big boost in your risk reduction in falls. And finally, Tai Chi has been studied, and quite extensively. And Tai Chi alone actually to reduce the risk of falls in our older patients by 23%. So these are the three forms of exercise that we really want to highlight for you. Um, Now, this is something we mentioned earlier in the talk. One of the big factors that we pay attention to, especially in our ambulatory clinics, are the types of shoes that our patients are wearing. So our feet, are designed, to actually ambulate and preserve a certain sense of gait so that it minimizes fall. But when you start wearing shoes, right, um, and the shape of the shoe, the type of shoe, it could really affect how your risk of fall is, increased. So to really highlight for you, so things are types of footwear that are loose, non-fitting, such as slippers, right? It's associated with high risk of fall. Are associated with a high risk of fall with an odds ratio of 2.4. Also associated with 0.8. And heels for two particular reasons. Boots often tend to be larger, bulkier, heavier. So patients, if the overall strength is decreased, they'll have a difficult time to actually maintain gait pattern, right? And heels are very high risk because it not only minimizes the your sort of tiptoeing, so it puts you at high risk of fall, but it also elevates you. Sense of balance also gets modified. And all the shoes were actually types of footwear were actually compared to which they used as a was used as a control for these different shoe types. Another thing that we really want to highlight for you guys is the USPTF recommendation against daily vitamin D supplementation. So this was implemented a few years ago, but this often comes up on the board. So prior to 2018, vitamin D supplementation was recommended for older adults to prevent falls or reduce the risk of falls. But when we looked at all the data preceding this, we realized that the evidence was mixed at best. Um, and so we are recommending it, and USPTF is mainline not to recommend vitamin D routinely for older adults, just to prevent falls. Now, obviously, if your patient has a low level of vitamin D, that's an supplementation is not indicated for that. The USPTF recommends screening older patients, especially female patients, um, for screening patients who are female and over the age of 65. And the ACP also for initial pharmacologic treatment to reduce the risk of fractures in postmenopausal females diagnosed with primary osteoporosis. And there is this, and this is one of the strong so in summary, 65 and older and female, the USPTF recommends that we screen them for osteoporosis. And anyone that screens positive for osteoporosis, separately, the ACP recommends that we use bisphosphonates for initial pharmacological treatment to reduce the risk of fractures. Another topic we really want to highlight for you. So oftentimes you'll encounter patients who complain of knee pain due to arthritis, or they have, they feel there, there's associated pain. Um, so pain is one of those a chronic pain, as I should say, is a huge risk for fall. It's a risk for fall because it's often a distraction because as you're ambulating and let's say you are experiencing really bad knee pain, you're going to be distracted. The pain is going to take away your concentration from paying attention the surface that you're walking on, any hazard that might be there, and it could really at risk of falling. Um, so to put it into perspective, when we look at the data for patients who have no pain versus pain, experience multi-site pain, right, due to multiple reasons, it actually is associated with a 57% greater risk of not only falls, but fall actually sustains injury. So managing chronic pain is a big component of actually preventing falls in our older patients. Now, risk of falls include optimizing, underlying cardiac and pulmonary diseases. So, for example, if you have a patient with COPD, and they need oxygen supplementation, but they're not, very compliant, you know, speaking to them about the risk of falling, about them becoming hypoxic and falling and injuring themselves, right? Or patients with underlying structural heart disease, such as heart failure, right? Optimizing them from a medical perspective, routine eye exam, and their prescription for their lens is appropriate. That's also critical. Oftentimes, many of our older patients are on medications, especially blood pressure medications that can cause postural hypotension. So really paying attention to the types of medications that they're on, right? Like a diuretic, for example, and podiatric care. Oftentimes, a lot of our older patients have chronic issues such as neuropathy, diabetes, or other neurological conditions that they may have. Um, they often encounter or get sustained injuries, and so pediatric care is also important and critical. So I'm going to transition to Dr. Ortiz, who will talk a little bit more about hydration and some of the medical conditions that are pertaining to falls.
Thank you so much, Dr. Kamal. So we're going to talk about other common comorbidities. One is like hydration and Parkinson disease and stroke. So basically, just to remind everyone how to measure the orthostatic blood pressure. So is you are going to ask the patient to lie down for 5 minutes. Then we are going to measure the blood pressure on the pulse. Then we are going to ask the patient to stand up. When we measure the blood pressure, then we measure the blood pressure in 1 minute and in 3 minutes. So the orthostatic hypotension is going to be considered positive if the systolic blood pressure decreases on 20 millimeters of mercury, or if the diastolic blood pressure decrease of 10 minutes or 10 millimeters of mercury, or if there is an increase in the heart rate of more than 30 beats per minute. So after talking about how to evaluate for the orthostatic blood pressure, we're going to talk about how to manage this postural hypotension. So basically, like we talked before, is to assess for the postural hypotension like we talked before. In the next slide, we are going to see like also the fluid the fluid optimization is going to be important, and we have to review medication that can increase the risk of orthostatic hypotension, like blood pressure medication. We have also to consider medication that they can be using for other reasons, like we talked before, medication for insomnia, for depression. So we're going to also treat the behavioral change. We can try to help with behavioral changes. So these behavioral changes can be like, be careful when they stand up. If they are waking up in the morning, or they were standing up from the bed, they have to sit on the side of the bed and wait for a few minutes before they stand up, so they can decrease the symptoms. And if we have tried or all these measurements and it does not work, maybe we can think or we can consider to start medication for orthostatic hypotension. One of them is midodrine and the other is fludrocortisone. If we decide to start this medication, is our last resort, and we have to consider too that even they help to improve the blood pressure, sometimes also can increase the risk of falls due to the side effects. So if we start this medication, we have to start in a low dose and then increase as needed. The risk for we always, like I said, we have to evaluate the benefits and the risk, because if we start, for example, the midodrine can cause strokes due to elevated blood pressure, or if we use fludrocortisone, it can cause edema, it can cause hypokalemia. So it's some side effects that always we have to consider, but this one that we can use for treating the orthostatic hypotension. Also, managing for the orthostatic hypotension, we have to manage the hydration. So basically, we have to know when our people age, our geriatric patients age, they are going to, the amount of the water in the body is going to be reduced, and also they are on increased risk of dehydration. If they have like any illness, also they are using diuretics, and we have to make sure, especially in the summer, we have to recommend the patient to hydrate well, because if when they get older, like we said, there is like the renin and aldosterone levels is going to decrease, and then they are going to be more prone to have falls. So hydration is important. Also, we have to be careful when they hydrate, that if they are using a lot of water, they have to put electrolytes in the beverage, because if some patients just drink water and then the sodium can go down, and then from the hyponatremia they're going to have more complications and also increase the risk of falls. Other conditions that can increase the risk of falls is going to be the Parkinson, and due to this is going to cause rigidity of the leg muscles, is going to put them in inability to correct the side trajectory, because the movements are now slow. Also, the Parkinson can cause hypotension, and also the medications that we use for Parkinson also can cause hypotension. And in some cases, our patients with Parkinson are going to have cognitive impairment. Another condition that we are going to evaluate when they have for the risk of falls is the strokes. So in the strokes can give the patients a visual special defects, and they can have impaired peripheral sensation, they can have cerebral dysfunction, and that is going to alter the gait. They can have muscle weakness due to the stroke, or they can have a residual dizziness. And finally, also we're going to talk about the vision. So it is important for the patients to be evaluated by an ophthalmologist at least once a year, because what happens is that it can have different conditions in the vision that can cause the increased risk of falls, and one of them that is very frequent in our patients is going to be cataracts. And it has been seen in a study that they did a trial with 306 patients, that there is a relative risk of 0.60% for people with cataract, and if the patient has a first cataract surgery, they are going to decrease on 34% the risk of falls. Now, Dr. Kamal is going to continue talking about medical reconciliation and birth list criteria.
Thank you, Dr. Ortiz. So we're going to really focus on high-risk medications. So I really want to highlight for you the Beers list criteria is a list of high-risk medications that we often are careful about, prescribing to our older adults. That for older patients, I should say, are prescribed especially for insomnia purposes or anxiety purposes. While in a younger patient, the risk might not be as great in an older patient due to generalized weakness or overall musculoskeletal weakness, um, also weakening kidney and liver functions. The body is unable to metabolize these medications as efficiently. So the effect is much more profound in our older patients, especially when it comes to falls. Some of the other medications that I want to highlight for you include TCAs, um, you know, um, Remeron or mirtazapine, specifically in the low dosages where the antihistamine dosage activity is predominant, and that could increase the risk of falls. We do sometimes use it in our patients for insomnia, but the timing of it is very important. You want to be aware that your patients are not taking that medication during the daytime as opposed to nighttime. Sometimes over-the-counter medications are used by patients, specifically Benadryl for the setting of insomnia. A lot of times, antipsychotics can also increase the risk of falls, and that's due to several factors. But one of them that we want to highlight for you include the anticholinergic burden that many antipsychotics often have, which could predispose our older patients to fall. So if you have a patient that is on an antipsychotic or on an SSRI, um, or any other psychotropic medications or pain medications such as opioids, it's important for us to really review them routinely and review the dosing and adjust them and even titrate them off if possible to really mitigate the risk of falls. For our ambulatory patients in the community, it's really imperative that we educate them on hazards around the home. Some of these we chatted briefly about earlier on, but the ones that we really want you to highlight for you include, removing like trip hazards, arranging furniture to give you like room to walk so that you're able to actually walk freely without your feet getting stuck. To really prioritize improving light. So if there's a light that's flickering or that's not working, really educating patients and their families to replace them. Um, Another thing that we often tell or share with our patients is to keep frequently used items within reach, such as eyeglasses, nowadays, cell phone, right? Chargers, things like that, at within arm's reach. Also adapting to furnitures and furnishings that have support so patients can grab onto them if they need to break a fall. We often encourage our patients to remove casters from the bottom of chairs and beds, um, so that they're more stable because they could, slide as you're trying to grab onto them. So we encourage patients and their families to remove casters and things like that from the bottom of furnitures. Additionally, we recommend using firmer cushions, or even double up, on pillows and cushions as patients are sitting down or laying down to give that extra level of support. All right. We also wanted to transition your attention to the CDC Fall Safety Checklist, and this is from the CDC's website. You could simply Google it, and this is, something, an education material that you can share with your patients, and it's very nicely organized, um, depending on the different parts of the house. For example, the stairs and the steps, keep objects away off the stairs, floors, to like remove rugs and things like that. In the kitchen, keep things that are lower, so that you don't have to try to climb anything. In the bedroom, place lamp close to the bed, and bathroom, use non-slip rubber mats to mitigate the risk of falls. So it's a really nice visual checklist that we could share with our patients. And that's all we had to share with you today. So if you have any questions about the talk. If you want to learn more, Dr. Ortiz and myself, we're more than happy to answer any questions. All right. Thank you.